Assalamu alaikum warahmatullahi wabarakatuh. My name is Sultan Sharari and I would like to talk about appendicitis. Why appendicitis? Because it's one of the most common cases that came to the emergency department. So let's talk a little bit about a definition or what is it. Appendicitis is defined as an inflammation of the inner lining of the vermiform appendix that's separated to its other parts. Despite diagnostic and therapeutic advancement in medicine, appendicitis remains a clinical emergency and is one of the more common cases of acute abdominal pain. Pathophysiology. Shortly, appendicitis is a condition where the appendix becomes swollen, inflamed, and filled with pus. The appendix is a small finger-shaped bush on the right side of the abdomen, connected to the colon. What about signs and symptoms? The patient will complaining of fever and diarrhea, losses of appetite, vomiting, and the location of the pain becomes more defined in the right lower side of the abdomen. It's called McBurney point. So I will show you next slide the location. Physical examination. The patient looks unwell and has low-grade fever. It's both sign and symptoms and tachycardia. Pointing sign, the patient point to the area of maximum tenderness McBurney point when asked. So, right lower quadrant tenderness 90%, there is a pain or discomfort upon application of pressure, breathing to the right iliac fossa. In case of retrocecal appendix, deep pressure may fill to iliac tenderness because the appendix is hiding behind the cecum. So we should to look at the patient, ask him to point to the point of the maximum tenderness. Palpate the right lower quadrant to see if there any tenderness, asking him to cough and press gently on McBurney point by your hand and release for any rebound tenderness. And muscle guarding when we look for any of those special signs. As you see, the first picture is McBurney point and second one right iliac fossa. The causes. It could be blockage of the opening inside the appendix, a large tissue in the wall of your appendix caused by infection in the GI tract, inflammatory bowel disease, stool parasite, or growth that can clog your appendical lumen, abdominal trauma. Risk factors. Most cases of appendicitis occur between the age of 10 and 30 years. Having a family history of appendicitis may increase a child's risk for the illness, especially in the male. Complications. If an inflamed appendix isn't removed quickly, it can rupture. When the appendix ruptures, it can spill the infection throughout the abdomen, leading to the potentially dangerous condition called peritonitis. That can lead to infection and inflammation of the peritoneum. The peritoneum is the membrane that lines the abdominal cavity and covers most of the abdominal organs. Peritonitis may cause the bowels to shut down. Bowel movement will stop and the bowel will become blocked. The patient will develop a fever, cold, go into shock. Peritonitis requires urgent treatment. So open obstruction, the wall from mucosa to serosa is inflamed and there will be continued mucosal secretion resulting in luminal distension by mucosa. This will increase the intraluminal pressure, causing stasis of lymphatic flow and venous congestion, and may compromise arterial inflow, leading to ischemia and thrombosis. Bacteria overgrowth inside the distended appendix occurs. With time, this causes infraction tissue, death, or necrosis, ulceration, slough out of inflamed and necrotic tissue, and eventually perforation rupturing. Investigation. The first one, it will be physical examination, and there is 3 tests that going to help you assess if the patient has appendicitis or no. Reversing sign, source sign, obturator sign. Second one is lab test, and you have to look a blood test to check for a high weight cells count, which indicate infection, and you have to check urinalysis just to make sure that urine tract infection and kidney stone not the cause of the pain. Pregnancy test. Third one is imaging test like ultrasound, just to see if the appendix is inflamed. If the patient present with the typical presentation, should do physical examination. And then CBC, this is enough to diagnose him as acute appendicitis. If the patient is a child, elderly, a pregnant lady, or in case of different location of the apex of appendix, you should go further in your physical examination and investigation according to the what we discuss shortly to exclude other condition. If you debit the diagnostic laparoscopy may be performed. Management. Analgesic like morphine sulfate 10 mg can be administered after the diagnosis is made. Resuscitation to correct or prevent fluid and electrolyte imbalance, and dehydration IV fluid administered. Appendectomy patient with sign symptoms consistent with appendicitis should undergo appendectomy surgical removal of appendix as soon as possible to decrease the risk of perforation. So, in patient with minimal clinical sign, uncomplicated acute appendicitis, non-operative management with antibiotic only is an acceptable option, although there remains a risk of recurrent in the future. So my case scenario is a 32 years old male with the right lower quadrant abdominal pain. He said, I have severe pain in my abdomen with no past medical history. Present to the emergency room with 24 hours of abdominal pain. The day prior to presentation, he developed diffuse vago abdominal discomfort. He lost his appetite. With following morning, the pain worsened in intensity, become sharp and localized to the right lower quadrant. The severity was rated 8 on a scale of 1 to 10 with a stable vital sign. And the abdominal examination revealed a soft abdomen, tenderness, on percussion rebound tenderness in the right iliac fossa, and a positive source sign he was not peritonitis and absent hernia. Investigation. I was taken from my patient CBC, and the result was white blood cells 13,000, which is sign of infection. Also urinalysis, and he has no evidence of urinary tract infection. After ultrasound, we see inflammation of appendix, which is appendicitis. Physical examination, all of them is normal except abdomen. He has right lower quadrant abdominal pain with rebound tenderness. Differential diagnosis: a 32 years old male with right lower quadrant abdominal pain. He said, I have severe pain in my abdomen, urinary tract infection, gastritis, appendicitis, ruling out according to the patient history and physical examination. Urinary tract infection, the result was normal according to the urine analysis. Gastritis, the pain was specific in the right lower quadrant and of abdominal and not generalized in the abdomen. Patient diagnosis: according to the CBC that shows elevation in white blood cells was 13,000 a sign of infection or inflammation. Also, there are rebound tenderness and right lower quadrant of abdomen by physical examination, and according to the ultrasound that shows edematous appendix. The patient diagnosis is appendicitis. Final state of patient: admission, preparing for appendectomy surgery. Treatment: he was comment in the following medications: electrolyte solution infusion 1000 ml IV, paracetamol 1 gram oral, morphine 10 mg oral, metronidazole 500 mg IV. Following this, he was transferred to theaters for surgery. Learning points: patient with suspect appendicitis should be emergently prepared for possible surgery. They should be nail bare os, nothing by mouth. A ruptured appendix separates infection throughout the abdomen cause peritonitis. This condition is life-threatening and requires immediate surgery. Rebound tenderness in the right lower quadrant. This method is especially useful in diagnosing appendicitis. And this is my reference. Thanks.